what has happened relatively good for us is the availability of many of those expensive oral medications, which are now available as generic formulations also. So broadly speaking, any drug which acts on the immune system, I mean, believing that multiple sclerosis is thought to be a disease which is autoimmune, which means that your own cells start to recognize your own tissue as abnormal. So it's kind of a self-destructing, but we do not know what are the inciting factors for that. So whenever you have an autoimmune condition, broadly speaking, you are treated with medications called immunomodulators. So the drugs which modulate your immune system to stop them to malfunction or misbehave, or even if there is an inciting factor, they keep the systems under control. It's like taking an anti-allergic medication for someone who has a frequent attacks of allergy. So we keep those systems down to malfunction. So one of the group of those drugs which are used as broad spectrum for many conditions in medicine, neurology, gastroenterology, rheumatology, and so on are called immunosuppressive medications. They suppress the immune system. Two of those most frequently used agents are azathioprine and another one is called mycophenolate mofetil. Both of them are available as oral tablets. And for many years, we've treated many of our patients on using these two agents, especially when patients are not comfortable in taking injections, or when the oral formulations like dimethyl fumarate and teriflunomide were yet not available, or when they started to be available, they were very expensive for patients to buy. And there were patients who were not comfortable in taking interferons because the cost was almost like 25 to 30,000 or average 15 to 30,000 a month. So many of those individuals, I think amongst all the panelists sitting here would have experience of giving them the option of treating with azathioprine or mycophenolate because logically they are immunosuppressants and they will definitely should work. And we have evidence from the literature even for in the past many years that these drugs are not ineffective in managing multiple sclerosis. So their room still exists for some people who for whom cost really matters, even for 1,000 or 2,000 rupees a month. With the advent of the generic formulations, the cost can of these drugs like teriflunomide or dimethyl fumarate could go as low as to 3,000, 3,500 a month, and two ranging from almost 3,000 to maybe 5 to 5,500 a month. Even if you give mycophenolate mofetil to this patient, which would potentially be thought of not a usual drug which people would use worldwide for MS because of its inherent immunosuppressive property, the cost could be almost 6 to 7,000 a month. So we have come to a point where we have options to choose from for both immunosuppressive and the immunomodulator drugs, which have less immunosuppressive potential. So if you talk to an individual or talk to a patient and tell him and explain him all the risks and benefits, as Dheeraj had also pointed out on a shared decision-making approach, many of the patients get worried when you tell them that these drugs have immunosuppressive property, not that the other drugs like dimethyl fumarate or teriflunomide don't have it, but when you see them listed among the so-called approved drugs by different medical agencies across the world, we need to tell patients about availability of these drugs as well. So the perspective is wide, and I think we as physicians are responsible to discuss all the options with the patients, and wherever feasible and whichever is suitable to an individual, whether it is azathioprine or it's mycophenolate or it's teriflunomide or dimethyl fumarate, we need to make the choice. Now, you could have a patient who could afford, but is not comfortable with a daily tablet. He says, I'm not compliant, and his family says, I'm not compliant. You need to tell them that there are options with low frequency interferon available. And there are patients who choose them because they can afford and they are more comfortable taking once a 14 days therapy. And there are patients for whom cost really matters a lot. And we may have to choose even azathioprine rather than the other available agents because for them, 1,000 to 1,500 cost saving a month is critical. So I think it is a individualized approach. And the good thing is we have a lot of landscape to choose from. Thank you so much.
Yeah, Dr. Dheeraj, there are a couple of questions directed to you specifically. We see prescriptions with tons of multivitamins and antioxidants written for patients with multiple sclerosis. So, what would be your take on that? And any specific dietary modifications or dietary advices which you would tell these patients, and the role of
Roll off.
exercise.
Yeah, sure. So I'll take them one by one. Multivitamins. I am in general not an advocate of multivitamins in any neurological disorders, and fortunately, none of the uh, well planned and well executed studies have shown any evidence of any vitamins. Yes, specifically in multiple sclerosis, the only vitamin which has a proven role is high dose vitamin D, which has been specifically proven mainly from data from the West, that having low vitamin D levels does have poor kind of a, it may indicate, or it may lead on to poorer outcomes. And also, lower vitamin D levels in childhood have been associated with a higher chance of having MS in later life. So, vitamin D is something that I routinely advocate and prescribe to all our patients, a high dose, 60,000 units, which we can give either initially. And also, we do baseline levels as part of our workup to look at their levels. Usually, it is low in our country. So adequately give them once a day for a few days, 5 days, and then a weekly, and then monthly. There was some hope from a vitamin called biotin, which came up recently for secondary progressive MS. The first two phases of the clinical trials gave very good hope of high dose biotin using 100 to 200 milligrams, which is not, unfortunately, not available in our country. But the first two phases gave us some hope that they tend to improve the strength in secondary progressive MS. And I started using it very rampantly. But now we've had the third phase 3 trial, which came up recently. And the data is very strongly suggestive of no major role. So I've even weaned off patients of biotin. So that was one hope which came up. Apart from that, yes, people do resort to a lot of vitamins. I do tell them that this may not specifically help, but it helps them, regain a psychological advantage as providing them some strength. They are most welcome to do, especially if they're not taking an adequate diet. So, diet, as you mentioned, a good diet which is recommended for MS is almost as we recommend for non-communicable or cardiovascular diseases, and specifically in MS2, good vegetables and fruits. These have been advocated. There have been a lot of fads available on the net about eating sardines, about avoiding lactose, about avoiding gluten. There have been no evidence. Emerging data on microbiome studies is still forthcoming, and we ourselves at our center are doing those. So maybe there may be an association of diets in different regions of the country or the world that we may be able to come up with after microbiome or the gut brain axis tells us whether specific diets do they lead on to higher inflammation or not in MS. So till that time, I would not say that any specific. A healthy diet, which has a lot of fruits and vegetables, would be recommended definitely. Exercise, the role is clearly the role of exercise is very salutary. It has to be overemphasized for various reasons. One is an exercise for general health. In MS, it clearly plays a very effective role, and now we would categorize it for different kinds of patients. Patient with obesity definitely has to lose weight with exercise, and an exercise program may not be very intensive because intensive exercises may precipitate a relapse. So we tell them moderate exercise. As far as obesity is concerned, it has got a clear bearing to poorer outcomes in MS, and of course having chances of diabetes. So diabetes and overweight both need to be avoided in MS as they reduce as they are associated with poorer outcomes. And the second part of exercise, which needs to be highly I would say, overemphasized, is in SPMS patients who have gone on either a wheelchair or even are on walking sticks. Their exercise is, I would say, of immense value. The reason is the cardiovascular component goes off. So we need to tell them through take recourse to stationary cycling or exercises which they can do on a stationary basis. Typically, cycling is what we recommend them to do, or any kind of exercise which raises their heart rate, because not only are we putting them at risk of having greater decline in function in MS, we are also putting them at greater risk of having cardiovascular dysfunction, which happens to be also a fact in these patients. So exercise at all levels, at all types of MS, at all stages of MS should never be undermined. The importance of exercise.
Yeah. Thanks, Dheeraj. Dr. Tapas, there are some specific questions directed towards you. One is, suppose a person develops a relapse of MS during these COVID pandemics, when there was, say, a second wave or when there was a first wave. At that time, what would be your treatment protocol? Will it be the same as a non-COVID era? That is one. Second is, would there be any changes in your follow-up protocols of patients during COVID and non-COVID era? And third is the role of dalfampridine in patients with multiple sclerosis who have walking abnormalities.
Thank you. It's a good question. I think in this COVID pandemic, one has to be very careful in starting off the patient on, high-end immunosuppressives like alemtuzumab or even rituximab. I think the safe options during this particular period is probably interferons, the glatiramer. You can give teriflunomide or fumarates, but I think the safer options are those injections. And if the patient has aggressive disease, then natalizumab is also a safe option rather than giving them the B-cell depleters or alemtuzumab. So I think we will choose for those drugs which are safe during this pandemic and ask them to follow these COVID protocols during their behavior, using mask and all those other things. So that's what I do. I tell them that way.
No, I had a couple of more questions.
Okay.
If the patient develops a relapse during this thing, then would you give him steroids?
Yes, that is also very difficult. If they have a mild relapse, of course, you can say if it's a mild relapse, it can, the patient can have remission spontaneously. But if it's quite a significant relapse, we have to give them steroids. There's always a risk that the patient can have COVID flare-up, or you have a worsening of the disease within a few days after giving this pulse prednisone therapy. So mild relapse, I think I will let them go and see if there is a spontaneous remission. If it's a high-end relapse, we have to give them steroids. We don't have any option in that case.
And the third was the role of dalfampridine in patients.
Dalfampridine, actually, I give in progressive kind of multiple sclerosis. Some people say, okay, they have got, my experience with dalfampridine is not that great. Patients don't say that. They sort of have a tremendous amount of mobility after using this drug. But those with the progressive multiple sclerosis, some patients say they found after using this drug, the mobility is a little bit better. That is my experience with this drug.
All right. Thank you, Dr. Tapas. We have Professor Nirmal Surya, who is the President-elect of Indian Academy of Neurology. I think he's two-timing. He is giving a lecture on the WFN, and he's also present here. Professor Nirmal, sir, are you there?
Yeah, I'm very much there.
Yeah. Welcome, sir. How are you doing?
I'm fine, thank you.
Yes. So I had a question for you, because your primary area of interest is rehabilitation. So what is the rehabilitation protocol for patients with multiple sclerosis?
All right. So, rehabilitation is a very complex formula to give it to the patient with MS. One really need to establish multidisciplinary team, and who is the one who is going to treat the patient first or who is going to be the part of the team taking the role and lead. Now, the challenge comes is the higher the EDSS, the more the need of neurorehabilitation of multidisciplinary team in those patients. Because if anybody who is above 3 or 3.5, he would definitely require the therapy in the form of physical therapy. And as you have rightly pointed out, the treatment along with physical therapy and multiple problems like fatigue, cardiovascular, age-related problem, though most of the patients are young, so we could take them into a little bit more aggressive therapy. Then comes is developing the skills, modifying their ADL situation at home or at the workplace. So role of occupational therapists. But those patients who have EDS above 5 or 6, they might find difficulty with speech and language. Some of them may have a swallowing disturbance if the predominantly brainstem lesion MS is there, and they would really look after with the speech therapist. Those with lesser EDS and on the disease modifying drugs might have a lot of cognitive disturbance. And therefore, a neuropsychologist evaluation in each MS patient at some stage and maybe regularly has to be done, because cognitive problems could be a mood disturbance, depression, anxiety. The other could be memory disturbance, forgetfulness, and they all need to be really taken care in this patient. Then you can have an associated other issues like social worker is required to help them out, uh, wheelchairs, assistive technology. So orthotics might be required in anybody who is above 4.5 or 5 EDSS. So rehabilitation plays a very pivotal role. One need to really require at what stage of disability the patient we are seeing, and who is going to intervene first or second or together. So that's where, Sumit, we really need to look at. But I tell you, each and every patient, rehabilitation would be a very, very important point, whether it is cognitive, psychological, or motor, or other. Thank you.
Thank you, Professor Nirmal. Dr. Netravati, I am giving you the most important and the most frequently asked question by patients with multiple sclerosis during this era. That is the question about vaccination. So, what would be your answer to a patient who asks you that I want to get vaccinated for COVID-19? When should I get vaccinated? What would be my check boxes which I would be doing before I get the vaccination done? And if I get the vaccination done, which vaccine do I choose?
Thanks, Dr. Sumit. COVID vaccination is a must. Most of the time, I tell the patients the first time we'll have two sets of patients who may come to us. That is, first one is they have come to us in the first clinical episode. Now we have diagnosed them as MS, or they were diagnosed MS, have come with relapse, not on treatment previously. The other is stable patients of MS who are already on treatment. So let me address both of them. So the patient, when they come to us first, if we are able to treat them with the steroid initially and taper off the steroid, I usually ask them to take the vaccine after the effect of steroid is gone, so that the antibody response to the COVID vaccine would be more better before we start any disease modifying agent. Of course, if the patient's relapse is severe and patient has not completely improved with steroid, and we may have to start the disease modifying agent. And if the disease load is not very high, then would try to give a disease modifying agent like the oral disease modifying agent, so that they can tide over the period, take the vaccine, and then switch on if it is required to switch on to a highly disease modifying agent. That is the first thing for a new patient who has come. Coming to the patients who are already on various disease modifying agents, how to time. Always stress upon the fact that vaccination is a must. And many of the time, the question what they ask is, why do I need to take vaccine? Is there going to be a relapse on taking the vaccine because I'm a patient of demyelination? And I was told previously that taking any vaccination could trigger a relapse. This is the question most of them come to. So what we need to stress upon is that all the available COVID vaccines are non-live vaccines. They are killed or a subunit vaccine. None of them are live vaccines. And the risk what was mentioned previously for MS patients are mainly with live vaccines, especially with yellow fever was mentioned previously. So we are not having any of the vaccines which are live. So we should tell them that any vaccine, it can be taken. There is no issue. The risk of relapse is less, especially if they are well controlled with the disease modifying agent. But it has to be timed very properly so that they do not have a relapse. So coming to the interferons, glatiramer, no issue. But only problem is many of these patients can have increased temperature or fever, which can cause a pseudo relapses in them. So always tell them to start the paracetamol prior to giving the vaccination, at least half an hour to 1 hour, and then continue it for 1 to 2 days, especially in those patients whom we know that they have a temperature sensitivity or a Uthoff's phenomenon like symptoms in the past. So that will help them to tide over that period and do not have a pseudo relapse. And on oral disease modifying agents, no issues, whether it is teriflunomide, dimethyl fumarate, fingolimod, no problem. They can continue the medication as well as take the vaccine. Coming to the injectables, that is the anti-CD20, especially the rituximab, I always tell them, give a gap of 90 to 100 days after your last rituximab, and then that would be the ideal time to take the vaccine. But there was a time when we were going through the second wave, and many of the patients were especially working in places where they are highly exposed and they can't wait for the next 3 months. Then at least wait for 4 to 6 weeks if possible. That would be the thing to be told, but if possible, 90 days. And if they're already due for rituximab, wait at least for 4 weeks. That is, they take the vaccination, finish both the doses, wait for 4 weeks, and then take the rituximab. So 4 weeks before, or if already taken, wait for 3 months or 90 to 100 days after you take the vaccine. Main thing is it should not be a waste of taking the vaccine, because when the vaccine, if you're taking very close to these anti-CD20 therapies, what happens is the antibody response won't happen. So if we time it well, then the antibody response will happen to the vaccine and they can have the benefit of the vaccine as well as not having the relapse. Coming to the natalizumab, most of them will be at either the standard dose or extended dose, either at 4 to 6 weeks interval dosing. So I always tell that keep a 1 week gap prior and after. That is 1 week prior to and 1 week later, so that there is no issue in taking the vaccine. So most of the time it is addressed like this. I think Dr. Meenakshi has asked about fingolimod also. Is it same? Yes. Fingolimod, only thing is that if they are well controlled on fingolimod, there is no problem. Whatever the literature says now, there is no need to stop. Coming to the other agents which are not disease modifying, like azathioprine, mycophenolate, and some people can be on cyclophosphamide. Again, azathioprine, mycophenolate, no issues, but if possible, if the disease is well controlled, just skipping for 1 week to 10 days is not a problem, especially if they've had a COVID in the recent last 2 to 3 months. Otherwise, actually, there is no need to stop the azathioprine or mycophenolate. But I have just only if they have had a relapse or if they've had a COVID infection, then we try to ask them to withhold for 1 week, 10 days, and then take the vaccine. With cyclophosphamide, yes, the risk is slightly higher. Just when the 3 weeks is almost about to finish, that would be the ideal time to take. But otherwise, with cyclophosphamide is a little bit riskier. Then apart from all this, the main thing, the steroids, which we would have given to them. So if they are on steroids, one thing, there is something called as a high dose steroids and a low dose, especially if we have just giving them pulse steroids. pulse given at every 4 weeks interval, then try to time your vaccine at the 3rd week or the 4th week, especially after 2 to 4 weeks. But if they're on oral steroid, then if they are well maintained, try to come at least less than 20. Otherwise, actually what they is told is that you should try to stop the steroid and then give the vaccine. But there are patients where you can't completely stop the steroid, especially our MOG related patients. In such patients, at least come down to the lowest dosage, less than 20, and then give the vaccine. So that would be, and coming to the last part as to which vaccine is better. We know that what we have, the choices are, one is the killed vaccine as well as the subunit vaccine. Both are quite efficient, but if you want to time your disease modifying agent, giving 3 months interval for a Covishield vaccine would be slightly difficult. Like I've had a patient who's had a relapse, we've given steroid, can't wait for 3 months to start a disease modifying agent. And during that time, we can ask them to go to take Covaxin so that within 4 weeks, they would have completed the vaccination. And then we can ask them to take the disease modifying agent. But otherwise, actually, there is no problem in both the efficacy of between both Covishield as well as the Covaxin and the Sputnik also, which is available now in India. Only thing, if they have a risk factors, uncontrolled diabetes, uncontrolled hypertension, only in those cases, slight preference towards Covaxin. That's all. Thank you.
Thanks for such an elaborate answer. And I'm reasonably sure most of the questions pertaining to vaccination, DMAs, and stage of MS must have been answered with this. Dr. Lekha, there are questions related to mitoxantrone. And the second question is, when do you stop the disease modifying agents or switch them over to something else? These questions have come up.
So I don't give mitoxantrone, and I don't see any need to try mitoxantrone in the current scenario when you have aggressive alternatives to try, which is much, much safer. Professor Singhal, if he was here, he would have told you out of the small number of patients he treated with mitoxantrone and he published, he told me that at least 25% of them later on went to develop treatment-associated leukemia, I think, treatment-associated of some form of malignancy, and cardiotoxicity and so on and so forth. I don't think we need to consider mitoxantrone in the present scenario at all. So I think the older concept of treating with platform therapies, then escalating to stronger medications, I think people are moving away from it. You know, at the onset, if the patient comes to you with aggressive disease, which again you would define by the number of relapses in that short period of time, the lesion load you're seeing in that patient, young pediatric onset or borderline pediatric onset MS, which is again much more aggressive in terms of the relapse rate and the lesion load, I think you can straight away start off with an stronger medication, a second liner, rather than stick to you know, these interferons and glatiramer acetate, which are fading away. Literally, I keep saying they're like ambassador cars. They take you from point to point, but definitely not going to do the job the well as it should. And we also now know that no evidence of disease activity, NIDA 3, NIDA 4, they fail miserably after the first few years. So therefore, there's no point in giving them medications of that sort when you have more superior alternatives. And people like me, again, I come back to the situation I work in. I find that rituximab and other anti-CD, I mean, that's the only anti-CD20 molecule that we have right now, which is the generics are so affordable and we get them at very competitive rates. I think Netravati would agree with me that rituximab is affordable, considering, I think for you, probably Netravati, it is free in your hospital, maybe.
Yes, the first 2 doses we get free for many of our poor patients.
For me, I get them very subsidized at less than 50%. And therefore, that's a very affordable, aggressive treatment to give from the onset if I feel the disease is aggressive by my definitions and what is described as significant MS at onset. Otherwise, the first line drug that I would go for is maybe dimethyl fumarate. But again, you know, I'm restricted by the fact that if a young woman comes who's just married or who's planning to get married, DMT starting with dimethyl fumarate is not going to help me really, because that is not going to be a safe option for her in her pregnancy. And that's where you get stuck, because I do not have a first line safe drug. And here's a woman who has had a number of relapses and she's come to me for therapy. So that makes it very difficult. And that's some of the times that I resort to drugs like azathioprine, because azathioprine is safe in pregnancy. Azathioprine given in mild to moderate MS at onset with a little bit of steroid help initially and subsequently tapering of steroid and maintaining on azathioprine. She can, she can go ahead, she can plan her pregnancy. Like as an earlier speaker had said, if her disease is mild at that point, maybe she can even skip azathioprine, but it is not an absolute contraindication to be on azathioprine while you get pregnant. Breastfeeding is safe. And then if by chance a disease escalates, then you're giving her an opportunity to consider higher therapies. This happens to me always. So when do I start change course? I am very, very much worried about the results of the interferon trials and all those, which have told us that earlier course correction is extremely important for later onset stability of disease. So as I said earlier, the patient while on regular medication with whatever drug you have given, first liner, and you find that there is definite history of breakthrough relapses while being compliant, and it's definitely at least 2 or more attacks. It may be episodic. Some of these patients do not have clear-cut attacks, but they continuously say that my leg goes numb, my leg periodically goes weak, and then I get better, but that nagging, niggling symptoms are there. And at least 4 out of 5 of them, if you were to do scans on them, you're going to find new lesions. So if you have new lesions on scan, and those are accompanied also by lack of freedom from symptoms, even if they are not necessarily new or dramatic attacks, I would still consider course correction in those patients and escalate them to a second liner. And my second liner, by virtue of no choice, is rituximab. I prefer that. I don't have patients who can afford anything else. So that's how I go. But that's a general trend. That's course correction is required very early, and whatever your patient clientele can afford, you can give them more wider choice than I can. And that's a way to go.
Thanks, Dr. Thanks, Dr. Lekha. There are several questions in the chat box and the question and answer box, which are personal and related to the disease of that particular individual. I don't feel at ease on discussing them on a public platform. I strongly recommend that if you have those questions pertaining to your own health or your own disease, you contact the doctor who's treating you and get those issues addressed. So I think we are at the fag end of the discussion, and I would like all the esteemed panelists to just give a 1 minute maximum message for the patients with MS on the World Brain Day, starting with Dr. Lekha.
So as an MS specialist, I think we are glad about the times that we live in the sense that when I started off 15 years, 20 years ago, there was such a hard time convincing even my neurology colleagues that this is the disease which deserves attention and these are disorders which are there in the community. Once I did my first population-based prevalence study for India, I realized that we are underestimating the impact of this disease and the prevalence of this disease. So even today, if you look at the modest prevalence that we've showed, around 8 per 100,000 with a 1.4 billion population, we have sufficiently large number of patients in the community. Unfortunately, most of them may not have been diagnosed, but there is hope for the future because newer generations of doctors are so much more aware of the disease, their ability to diagnose, and and the familiarity with the topic is so much more than it used to be 15, 20 years ago. And therefore, I am very hopeful about diagnosis. Treatments are still challenging, but as Rohit was saying, the generics are helping us a lot. The subsidized and competitive pricing that the pharma industry is offering us, that also gives you reason for hope. So I'm very hopeful on the whole.
Thanks, Dr. Lekha. Dr. Dheeraj, what would you like to give it as a message on the World Brain Day to MS patients?
Well, on this World Brain Day, I think my message to all people with MS and the MS fighters, as we call them, is that we are at a very I would say positive juncture where MS is concerned regarding their treatments, research, and the future prospects of very new exciting treatments. And I can clearly say that MS is now considered as a surmountable disease. We do not consider this as a very high unachievable challenge as it was decades back. And with a kind of newer research coming in and exciting results of new trials, there's great hope in even reversing the damage which is incurred in MS. And what I would like to tell all people with MS is to keep their spirits high, let their spirits not be dampened by problems with MS, and to look forward with greater hope for getting their condition in control, because as also Dr. Lekha mentioned, there is now a good deal of understanding in our country, and a lot of people who are dealing with MS provide excellent care to MS patients. So the future is good for MS. That's what I would say.
Rohit, what would you like to say on this day?
Rohit is muted.
You're muted.
I would just say that the first thing there should be no negativity. A lot of people read, Google, they come with a lot of, uncertainty about their life, their career. I think this is like another disease. We have people who have diabetes, we have people who have hypertension, we have people who have heart diseases, we have people who have chronic kidney diseases who are on dialysis, but they live a very positive life. I think this is like any other disease. We've gone very far on this. People are doing very well on treatments. And I think they just need to stay positive. They just need to stay focused, and they have freedom to do anything in life, anything they want to be. And the science and the doctors are there to support. I think they should just be very positive about this.
Thank you. Dr. Tapas?
Yeah, what I can say is that there has been a paradigm shift in the management of MS. It is very much a treatable disease now. All we have to do is to be aware of this disease and capture the disease at a very early stage. So if you can initiate treatment at the early stage, we can have we can give a very normal life to the patient by treating them appropriately.
Dr. Netravati?
I second most of the things what my previous panelists have told, especially what Dr. Rohit mentioned, that many of them are not scared when they're diagnosed with diabetes, hypertension, thyroid. I actually tell these to my patients, but the use of MS, and the moment they Google, they get scared just because of the hype around it. But what I would want to tell is, we know the illness much better now compared to what was there before. And there is a large armamentarium of medications which are available. And our aim is, as a MS fighter, as well as any patient, aim is try to contain the illness at the initial stages so that they will be able to lead a very productive, happy life. Otherwise, when they are, especially like what Dr. Dheeraj mentioned, the shared decision making. So that has to be there between a patient and a doctor, so that we know that they will be compliant with medications, adherence will be maintained, and they will be able to take the medications very well. And though there may be a little bit of limited approach in few patients, a lot of research happening, and many medications are going to be available in the future, which may address more better the symptoms. Thank you.
Thanks, Dr. Netravati, and I thank all the panelists on this World Brain Day to join us for.
Nirmal Surya for last comments.
Dr. Nirmal, sir, are you there, sir?
Yeah, I'm very much there. Thank you very much. I would like to say that there are a lot of gadgets for neuro rehabilitation available to the people. Even if you have disability, there is a hope. You have so many avenues to make you better and get you back to the ADL what you require. So neuro rehabilitation would be an integral part of therapy, medicine. Though the newer and newer treatments are available, which will bring back the patient to the less disability, but yet early identification of the disability in any form, whether it is neuropsychological, physical, or speech and language or other, is prime, and early intervention could make the life much better. So don't worry, there are a lot of things available for you, and newer therapies and newer rehabilitation are going to work together to make you better. Thank you.
Thanks, Dr. Nirmal. And so in the end, apart from thanking the organizers for giving me this opportunity and the panelists for being so active in this discussion, I would like to say that nothing is happening more actively on the front of science and medicine as it is happening on multiple sclerosis. So I think you should believe in science and believe that maybe a cure for MS is not very far away. Let's hope it happens during our lifetime. Back to Dr. Beshram, sir, for further carrying on. Thank you very much.
Yeah. Thank you, Sumit, and all the panelists. And I would like to also thank the print media and other media for taking part in this very important campaign. And as always, they have been very supportive and highlighting the important aspect of the disease. Now I request Dr. Meenakshi Sundaram for final concluding remarks.
Thank you, sir. Let me say on behalf of IAN, say a big thanks to all these wonderful experts to have spared the time to be here and educate our people. There are a lot of our patients who have logged in, and I'm sure they're all better educated now about MS. I think if there is something, I think the summaries have been done by the experts themselves, those on the panelists themselves. What I would only say is everything is getting better. We are, the technology is better, the times are better, science is getting better, medicines are getting cheaper. So have belief at any point, and as was pointed out, with all these things getting better, our abilities to diagnose the disease, Dr. Lekha did point out about the huge number of patients that might be going undiagnosed. So we're getting better. Everyone is getting better with better technology, with better knowledge. We would be able to tackle them better. And as Dr. Nirmal Surya pointed out, even if there is a disability, unfortunately, that can even be tackled better with today's technology being available. So if there is one word that all of us here would agree upon and tell you, if to all those warriors, as Dheeraj said, the MS warriors and the MS fighters, is that don't lose hope. There is enough arsenal available with all of us to conquer the disease, and we'll soon be probably, there's billions of dollars worth of research going on all around the world, and we're hopeful of better and better times. So thank you all. Stay positive, stay safe. Thank you.
Thank you very much.
Thank you. Bye-bye. Good night.
Thank you. Bye-bye.
Bye-bye.
Good night, everybody.
Good night.
Thank you.
Good night.
Thank you, Mansi.
Yes, sir. You're welcome.